fixation of acetabulum fractures. Then we're not going to take any questions during the presentation, but feel free to write your questions on the chat, please. And then after Francisco's presentation, I will then continue with fix and replace as an option in acetabulum fractures. And then after my presentation, we will then open the chat for discussion. Maritz Lobsha will monitor the discussion. So how we'll do it is that if you have any questions at any stage, please write them on the chart. And then afterwards, we will then read the questions. If we have any, or if we need any clarification on the question, then we'll ask you to put your microphone on and you can clarify some parts of your question. So yeah, without much further delay, I'm going to hand over to Francisco to get us started.
Hello, good evening, Professor Sithombo. Well, I would like just to double check that my presentation is available. 1 second. 1 second, I will check if I can start sharing my screen. Okay. Can you see it?
Yes, we can, Francisco. Perfect.
Okay. What about now? Full screen?
1 sec. Yeah, it's got full screen. Okay, no. It's not the full screen yet. And we can see where it's showing the slides on the left, and it has, I think, 7 slides showing. So,
but you see properly the full screen, or?
No. We're seeing but yeah, look, we can see the full screen. I'm not sure how you want to show it, but we can see the screen. So maybe if you start, we can see if it advances.
What about now? I am keep going.
No, it's not advancing.
Okay.
Try
so
again.
Let me do it in another way. Okay, let me guess if sorry for that. And now?
Look, we're seeing the same screen that we saw previously, but maybe just get started and let's see what happens.
Well, anyways, the first thing I have to say is thank you for organizing this webinar from OTC Foundation. We are really happy with your chapter. All over the world, we are 19 chapters, and we have to admit that the South African chapter is very active and it has a lot of passion about teaching, and we are really proud of supporting your local chapter. I cannot escape this opportunity of presenting you the OTC Foundation website. I invite you to discover all the events, courses, symposium, and fellowships that we offer, and also the support research with grants, publications, and symposiums with the RICO unit that support the investigation all over the world. So please don't miss our website and check what we have available to share with your local chapter. Well, we have a big problem when we have to face an acetabular fracture in an elderly patient. And there is not only one way of fixing that fracture. You have to consider a lot of options. I have experience with synthesis. I also have experience with arthroplasties. We have to identify the fracture pattern, the characteristics of the patient. Also, we have to be frank and honest with ourselves. We have to know about our skills. Most of the occasions, the acetabular fractures on the elderly patients are under the circumstances of low energy trauma. They fall on their side and they have an impact on the lateral part of the greater trochanter. So there is an anteromedial force that is going to displace the anterior column and also the quadrilateral plate. And the femoral head is going to be medialized and is going to impact the posterior medial roof. So if we consider the different fracture patterns, the most common fracture patterns in elderly patients, it is established that the most common one is the associated both column, followed by the anterior column, also the anterior and posterior hemitransverse, and followed by the posterior wall. And that's very important in order to know which approach we should use in order to fix the fracture. And we are surgeons and we love to do surgery, but sometimes we have to think it twice and consider which is the best option for any individual case, because we have a lot of alternatives in order to treat these fractures, from a conservative treatment to minimally invasive techniques, conventional open reduction and internal fixation, and also the primary total hip replacement. If we check in the Bible of the acetabular fracture, for me, that one is the tile book. And we have these recommendations when we have to face these fractures. For patients.
To interrupt. Sorry, 1 second, Sithombo here. Your screen is not advancing. I'm not sure if you want it to advance.
Yeah, I have been advantaging for at least
no.
50 slices. That's why.
sorry, it's not advancing. So please try.
Okay,
again.
So I will
start again.
I will start again, and please tell me if it's advanced or not. Okay, what about now? Do you
just advance the slide?
Yeah, I am advancing the slides.
No, it's not moving. Maybe
it's not moving.
Switch your screens around.
Okay, sorry for that. Let's check it again. Well, okay, I will do another option that maybe it's gonna fix this problem.
Okay, that looks good. Oh, it
I
did
think I have the solution for that. You're gonna check it. Just give me 1 second to finish and address this problem. It's gonna be like this. Okay.
Okay, now we've got full screen.
Okay,
now that's better.
Now you got it, right?
See, now those are the graphics I was expecting to see from you, all the fancy graphics.
Okay, here we go. So, well, again, I was just introducing the OTC Foundation, and I was inviting the participants to join to the website that we have available in order to know all the courses, events, symposiums, and forums that we offer, and also the grants for research. We have 4 grants available, and they are pretty important. They are 50,000 euros, so please don't hesitate and ask for them, because they can be really useful in order to promote your local chapter. And as I was saying, when we have to face acetabular fracture in an elderly patient, we have several options, and we have to consider the whole entity of the fracture, not just the fracture pattern. Also, you have to consider the type of patient and also the experience that we have with the surgery. As I said, normally they are low energy trauma, and these patients fall on their side with an impact through the greater trochanter that is causing a force displacing the anterior column and also the quadrilateral plate, and the femoral head gets medialized and impacts the posterior medial roof. So that's important to know how we must address this displacement. And if we consider the type of fractures that these elderly patients sustain, most of the fractures are associated with column, followed by anterior column, anterior and posterior hemitransverse, and posterior wall. So that's going to be important for the decision of the surgical approach. And as although we are surgeons and we think and we love surgery, we have to think twice which is going to be the best option to offer to the patient, because we have from conservative treatment to less aggressive to classical open reduction and internal fixation. So if we have a look in the tiled textbook, we can check that there are really clear indications for conservative treatment. That will be a patient that is not ambulator and that is living in a nursing home patient with a severe osteopenia or with a non-displaced fracture. In those situations, we could do the conservative treatment. On the other hand, if the patient is functional ambulatory and is able to tolerate the surgery, if we are going to be able to get a reduction through a non-stencil approach, we could offer the open reduction and internal fixation. On the other hand, if the fracture is really displaced, we are not going to be able to address everything through a single approach. And if the patient has significant pre-existing arthritis, maybe the best option will be to go for a total hip arthroplasty. Thinking about the conservative treatment, time ago, we used longitudinal skeletal traction and also lateral trochanteric skeletal traction that could be like a nightmare for an elderly patient with a lot of complications associated. Another option will be just to leave the fracture by itself without any traction, just controlling the pain, seating the patient as soon as possible, obtaining good results in non-ambulatory patients, as you can see on this case, that with 98 years old, the patient was able to control the pain. Another example of conservative treatment, it was not intended conservative treatment, it was underdiagnosed fracture during the COVID pandemic. This 84 years old with a horrible X-ray had a very good functional result without any pain or complaining. So maybe that was a good option, although it was not intended to be. If we move to the open reduction and internal fixation, we can do this more commonly because several reasons. The first reason is that we have orthogeriatric units, and with this in this interdisciplinary care program, we know more how the patients suffer from polytrauma in the elderly stage. And we know that even in critical patients, we have a high significant survival rate. Another reason why we can operate more commonly the patients is because we know better how to perform the technique. OTC Foundation can help with that, giving the support with fellowships and hands-on training with different courses. Also, we can operate more commonly the elderly patients because we have available new approaches. The first approach will be the percutaneous periacetabular screws. In order to properly insert these screws, we really need to know the corridors, the bony corridors, in order to know where to place them in a safe manner, because it's really appealing using by minimal incisions just these screws to fix the fracture. However, these are mostly indicated for non-displaced fractures, and some non-displaced fractures can be treated conservatively. So we have to think really twice if it is going to be useful for the patient or just useful for the surgeon. Other options that are really useful for these patients are the new approaches that we have in order to face the anterior column. I mean the STOPA approach and also the pararectus approach. These two approaches limit the use of stencil approaches and are really suitable for elderly patients. I will start with the STOPA approach. It's approach that it's based on a bikini line incision that is going to offer full control of the anterior column. This example, 74 years old, then incision starts transverse, a transverse incision. Then we go through the fatty layer up to the transversalis aponeurosis. That's the transversalis aponeurosis. I'm in my experience, I normally do open also this aponeurosis in a transverse manner instead of a longitudinal manner, because it's going to be more easily to identify the interval between the rectus muscles. So once the fascia is transversely open, you have to do a longitudinal cut in order to facilitate the movement and gain access to the anterior column, because if you don't do this longitudinal cut to this fascia, it's going to be really difficult to access to the anterior column. Once we identify the interval between the rectus, you can easily get access to the refuse space. And once you are in the refuse space, you have to lift the bladder with a malleable retractor, and you have to release the rectus from its incision, but just in the anterior part. The distal part is kept. You don't have to cut it. And while you flex the knee, you release the psoas and you start the dissection through the anterior and superior ramus, gaining access to the anterior column. Here you can see how we use different Hohmann retractors on the ramus, and with a malleable retractor, you identify this structure that is really, really common, the corona mortis, that is an anastomosis between the external iliac and the obturator vessels. And when you identify that, that is really commonly to see it, because you just face it, is in front of your face, you have to coagulate it in order to avoid any bleeding. By gaining access through the anterior column by releasing the fascia iliopectineal, then you have fully access to the fracture pattern of the anterior column, and you leave and create a space in order to place the plate that is going to be over this anterior column. And here you have fluid access to the fracture to make the reduction maneuvers, normally by pulling the leg and by pressing. And just the remaining part will be to do the fixation with the plate and several screws. Here is the postoperative CT scan. One more example. This 80 years old with an anterior column fracture, quadrilateral plate displacement. The patient was previously operated of an hernia, but that's not a big issue for this approach. You can see how easy it is to access to the fracture site from the anterior part and place the plate, and with a minimal aggression and with an anatomical reconstruction. Another example, 93 years old with an anterior column and posterior fracture of the acetabulum. A trick is to flex the knee. That's why normally I use these pods in order to keep the knee flex, and it's really useful. It takes less stress to the assistants. Here you can see the fixation, the dressing. Normally we use fascia block for the control of the pain. Post-operative control, second day, X-ray, 2 months. And remember, this is a 93 years old. And 1 year after the fracture, without the need of a crutch or any external device. You can see that the patient recovered the ambulation. One more example, 83 years old, a lot of comorbidities. Here, This is the corona mortis that is coagulated. Normally we use tranexamic acid once we finish the surgery in order to reduce the bleeding, the dressing, CT scan, and movement on the following day. In more difficult cases, we can add to this STOPA approach the lateral window, especially when we have to access to the ilium if the fracture is extended through the ilium. So the only thing you have to do is to release the oblique external oblique and also release the iliac muscle. Here, this patient, you can see how we release the oblique, external oblique. You have to go to the enthesis in order not to cut the muscle, just to release the insertion. Introduce with the cup, you release the ilium. With these forces, you can mobilize the iliac crest and use different plates in order to facilitate the reduction. You can see by using one screw, the plate is gonna help in the reduction. And once the fracture is reduced, you can complete the synthesis. This is the patient after 3 months in the clinic with a slightly limp, but with a good result. Another example with a STOPA approach with lateral window. You can see this transverse fracture. Normally, they are reduced by pulling the leg. Incision for the STOPA, lateral window, and through the combination, you can do the synthesis and also control the posterior column. Full movement, no pain, and no need of crutches or external devices. This is 76 years old. Another example, interpretive X-rays, STOPA and lateral window. This is the following day of the surgery. This was a very active elderly patient, 78 years old. You can see here after 4 months, the ambulation and lax example, 71 years old. The same STOPA approach combined with the lateral window. Lateral window facilitates the insertion of longer screws parallel to the sacroiliac joint. X-ray control, following day after surgery with the fascia block, and the control after 5 months with a good movement and without pain. And also we can go a step further. We can combine the STOPA with the lateral window and also osteotomy of the anterior superior iliac spine, especially when you have to gain access to the anterior part. It's a little bit more aggressive, but by doing that, you increase so much the control and the access without the need of doing an ilio-inguinal approach. I like to perform a drilling before doing the osteotomy and insert a screw that is going to be used in the end to reattach the osteotomy. Once the iliac, the anterior superior iliac spine is released with the chisels, you can see how much the access to the internal fossa is gained. Release, and by doing that, you increase so much the control, especially if you have to address more proximal fractures that can be really difficult to control and to reduce if you don't do this step. And once you are done with the reduction and the synthesis, the only thing you have to do is to use the same screw that you used before doing the osteotomy to address that osteotomy. This is the X-ray control. Another example of this osteotomy, this patient that suffered with 71 years old, this transverse fracture in a traffic accident with multiple injuries. And this is the X-ray control with the post-operative CT, where you can see how the osteotomy was fixed with that screw. Well, on the other hand, we also have a minimal invasive approach that is really common nowadays. That is the pararectus approach. It's based on a minimal invasive approach, but it gives you most of the advantages that you can get by doing an ilioinguinal approach. In order to do this approach, you have to identify the iliopsoas, the external iliac vessels, the obturator nerve, also the corona mortis, and the round ligament or spermatic cord, depending on the sex of the patient. And you have to play and develop 5 windows in order to do this full approach. The first window is bordered by the iliac crest and the iliopsoas muscle. The second window is contained by the iliopsoas muscle and the external iliac vessels. The third window is between the external iliac vessels and the spermatic cord or the round ligament. The fourth window is medially to the spermatic cord or round ligament, and the fifth window is contained by the external iliac vessels and the spermatic cord or round ligament below the pelvic ring and contained by the obturator nerve. So by playing with these 5 windows, you can control the fracture and you can do the fixation. The landmarks, the skin landmarks for this approach is a line that goes from the bottom belly to the superior iliac spine, and another line from this spine to the symphysis pubic. So the line should go from the medial part to the lateral part, to the lateral 3/3 part. Here we are going to have some examples. 76 years old. This is the landmark that I say from the medial part to the lateral part. Intraoperative images. Once the fracture is reduced and fixed with that plate, you can see how we have to mobilize the structures in order to generate and create the 5 windows in order to address all the displacement and all the fragments. This is the skin after the surgery, post-operative control, and finally control. One more example, 78 years old with this anterior column and quadrilateral plate. We prepare the belly and also the right extremity. We normally use compression devices in order to reduce the chance of a thromboembolic event. You have to, it's called pararectus because you have to go lateral to the rectus abdominis. Normally in elderly patients, you have a lot of fat. You palpate and you identify the lateral part of the rectus, and you open the seat in order to locate the place where the fracture is. You open the posterior seat of the rectus, and by doing that, you just gain the access to the fat and also the pelvis. You have to take care with the peritoneum because in elderly patients it's really soft. You can open it by soft movements. You can place that retractor on the ramus, identify the epigastrius vessels. You place that malleable retractor moving the obturator nerve. If you identify the corona mortis, you have to coagulate it or ligate it. And then you have to identify the iliopsoas and the vessels, external iliac vessels that are protected, mobilize, and here you start to see the fracture site. So the remaining thing will be to open the iliopectineal fascia and mobilize the iliopsoas with the nerve. And by doing that, you generate the 5 windows, and by moving those structures, you can reduce the fragments and insert the plate in order to counteract the displacement forces. This is the surgical incision, X-rays, and the patient the following day after the fracture. This patient sustained a superficial infection that with only antibiotics was controlled. It didn't need any debridement or any surgical treatment. Another example, 73 years old with this anterior column fracture with minimal quadrilateral plate displacement, also the pararectus approach, X-ray control, final. For the pararectus approach, you have to take care with the deep circumflex iliac artery that is just exiting in front of the epigastric vessels. So once you identify the epigastric vessels, just on the other side, you can see the exit of this deep circumflex artery, and you have to coagulate it, because if you don't do it, it can create a bleeding that is nothing so important, but it can be stressful if you don't take that precaution. Here we have a comparison between the pararectus and the modified stopa. It's true that with the pararectus, you have more control of the vessels and you have more access to the proximity of the sacroiliac joint, but it all depends of what are you familiar with. And I have to say again that you must take care of the peritoneum, because in the elderly patient, it is really soft. So it's really easy to open the peritoneum. Nothing important. If you open it, the only thing you have to do is just close it. But it can be really funny to find all the structures in the surgical field. So it can be tricky sometimes. One example where pararectus approach will be not suitable will be that this 83 years old patient that sustained also a colostomy. So that will be a contraindication for a pararectus. The same will be this patient with 65 years old with an epileptic status and bilateral acetabulum fracture. This was more easily addressed by doing an stopa approach, and with only one approach, the 2 acetabular were addressed. And I think that if you're familiar with the stopa approach, you can address most of the fractures. We are also able to fix a lot of elderly patients' acetabular fractures because we have nowadays available new implants that make things more easy. Because time ago, in order to address the quadrilateral plate, you need to modify the conventional plate in order to counteract the displacement force. However, we have now in the market some plates that have evidence that can improve the ability to achieve an appropriate reduction. Sometimes one thing that I do when I don't have fully contact of the plate with the cortical surface is adding some bone. You can have some graft and place it between the plate and the quadrilateral plate, and it can be another way to support and to maintain the quadrilateral plate in its place, because these plates, unfortunately, although they are considered as anatomical, they are not anatomical at all in most of the patients, and you have to modify those plates in order to properly adapt the cortical surface of the patients. For example, this case, we did an stopper approach, and we printed a 3D model in order to prevent the plates and to pre-contour the plate to the anatomy of this patient using the mirror imaging printing. And as you can see, we needed to modify previously the plate and pre-contour it over the model before inserting it into the patient. And that can be really useful in order to adapt properly the plates. And what do we have about evidence regarding the osteosynthesis of these fractures? There are few papers with a lot of bias, so it's really difficult to get a clear conclusion. In the rockwood, we can see that there is not a clear evidence if it is better the open reduction internal fixation or the total hip arthroplasty, and it all depends on the surgeon's preference and expertise. We can see that we have more complications that the osteosynthesis that we perform in younger patients, and that's obvious because it's more difficult to obtain anatomical reduction because the quality of the bone is not as good as it should be. So the outcomes should be less good as compared with younger patients. However, we don't increase the mortality, and it's not justified not operating these patients just because of the mortality rates. And a good thing is that it helps our decision not to operate more on these patients is because even with not good X-rays controls, the patients, most of them, are happy with the results, and the quality of the reduction in these all patients is not related with the clinical function. As you can see here, this patient, 82 years old, with an anterior wall fracture. We did an osteosynthesis. You can see that we have an heterotopic ossification, and even with that horrible X-ray, the patient had an excellent result and an excellent independent. The same, this other patient, where we were not able to control or reduce the fracture, the patient was asymptomatic. So we have to think twice once we get the X-rays controls. And this is a very, very important paper. And if you are going to just read one paper, please read this paper because it's really, really clear. When we are going to, when it's supposed that we are going to get worse results with an osteosynthesis. On these occasions, the first thing will be the gall sign, that is explained by the impaction of this area of the acetabulum. Also, other evidence that will be a sign of bad result will be the femoral head impaction, as you can see in this intraoperative image. Also, the marginal impaction, that in most of young patients we deal with and we reduce with grafting and racking screws, but in elderly patients, sometimes we don't get that good result. For example, this 72 years old patient sustain this fracture, we underestimated the impaction of the femoral head, as you can see here in the control, and of course, the result was not good, and total arthroplasty was needed in order to improve the quality of life of the patient. Another sign of bad prognosis for the osteosynthesis is a hip dislocation, as in this case. Also, the pre-existing osteoarthritis that will require a total hip arthroplasty. Also, the ipsilateral femoral neck and acetabular fracture that should be addressed with a total hip arthroplasty. And also, when we have a highly comminuted posterior wall fracture, as in this patient, 71-year-old, that was addressed with an osteosynthesis, but it was not able to control the stability of the hip and required a conversion to a total hip arthroplasty. Some papers recommend, even when we have impaction, to do the impaction and grafting of the fracture and using some rafting screws. Here, in this case, 78 years old, we did that through an Stopa approach. We did this, the impaction of a fracture. However, it was not able to contain the femoral head. However, even with this X-ray, the patient was happy with the result, and she didn't felt about conversion to a total hip replacement. Also, you can see that it's clear the limp that the patient has, but she is not actually complaining of any pain. It's really important for elderly patients to use the proper osteosynthesis with the proper stability. Here in this patient, we didn't use interfragmentary screw, and as you can see, there was a secondary displacement with the necessity to reconvert it to a total hip replacement. And this paper recommends that we must focus the synthesis close to the acetabulum in order to increase the stability by inserting screws close to the quadrilateral plate. The problem with these screws is that they can get into the joint, and if they get into the joint, the painful and the necessity to reconvert it to a total hip replacement is going to be the must. So if we use this kind of screws, it's mandatory to get a CT scan in order to control the proper position. And what about the conversion to a total hip replacement from an osteosynthesis? As we can see, it's up to 23%. And sometimes it doesn't matter if we get an excellent postoperative X-ray control. Even on these cases, we can get a bad result and the necessity to convert it to a total hip replacement. However, with most of the cases, we can get a very good result if we do a proper surgical planning. One example, 74 years old, with an anterior column fracture. This is the intraoperative image. That's the X-ray control that is not properly centered in the hip. We reconvert it to a total hip replacement. During COVID, the patient disappeared. She didn't come up to the office. And 1 year later, she came to the office like this. So we scheduled a total hip revision. This is the patient after the revision with great independence. After that, the patient suffered a subcapital fracture that was treated with a bipolar hip replacement. And here is the result of the patient. And just for the last part of the presentation, I know that Professor Sithombo is going to talk about total hip arthroplasty as an option for treating this acetabular fracture in elderly patients. But I just would like to say few collaborations from Spain to the treatment of these fractures. This article talks about the experience that they have using the limited anterior approach for a total hip arthroplasty, using this avascular space in order to get good results treating these acetabular fractures directly with an arthroplasty. Also, Professor Guerrado published this really cheap technique that is by using a plate, inserting a cemented hip replacement in elderly patients with good results. And this is my personal contribution to the arthroplastic for the acute fracture of the acetabulum, using the advantages of the acetabular revision surgery is by using the cap and cage technique that use the trabecular metal in order to facilitate the integration and the stability of acute arthroplasty. This patient, 85 years old, with previous pain in his left hip. You can see that the displacement is mostly of the anterior column. So we decided to go directly to a total hip replacement. We use the femoral head as graft in order to fill all the gaps. You don't look for the anatomical reduction, you just look for a stable place where to place the implants. You fill all the gaps with the femoral head. You insert the cap, the trabecular metal, and once that's fixed, you add the plate in order to complete the cap and cage system, where do you connect both components with a screw. And the last part will be to cement a polyethylene component and a cemented femoral stem in order to do this arthroplasty with these results after 1 month, 3 months. I say again that it was a 85 years old patient. This is 6 months, and this is after 8 years with 93 years. Another example, 82 years old, posterior wall with the dislocation that was kept dislocated for over 1 week. This is the X-ray control.
Meses de evolución. A ver, ¿cómo va de frente usted?
And 10 years after the arthroplasty. Well, that's all from my side. Thank you so much for your attention. And I guess that once Professor Sithombo will finish his presentation, we will have time for the discussion. Thank you so much.
All right, thank you. Thanks, Fran. So I'm going to come up next. So I'll try and share my screen, and please confirm if you can see my screen. Hey, can you see the full screen?
Yeah.
Okay, fantastic. So thank you very much, Fran. That was a very wonderful presentation. And so I'm going to continue now with the part that you touched briefly on, which is the fix and replace component of the surgery. So I'm coming to you from Cape Town for for our international visitors, and it's a beautiful city. And if you've come to Cape Town, you'll agree that it is the most beautiful city in the world. And I'm not being biased. It's not me just saying that. Consistently, Cape Town gets voted, the most beautiful city in the world. So if you haven't been to Cape Town, please make your way down to come and visit. So this is where I work, Grooteskier Hospital. It's on the foot of Table Mountain, and our biggest claim to fame, of course, is that this is where the world's first human heart transplant was performed in 1967. There's a beautiful museum inside the hospital that captures that wonderful moment. So again, if you ever come visit, please make sure to visit the museum. Okay, so just moving on. Now, many of us get faced with this kind of problem all the time. Elderly patient comes in with a neck of femur fracture. And here there's never any discussion whether the patient requires surgery or not. If the patient is fit and they can tolerate surgery. Are my slides advancing? Just someone confirm, please.
Yeah, you advanced from the first one.
Okay, fantastic. So when this patient comes in, like I said, there's never any discussion. It's always that, you've got a broken hip and that if you're fit for surgery, we need to operate. And the advantages are numerous, including the fact that you can mobilize immediately and that if you leave them in bed for a long time, they get complications of recumbency, etc., etc. So there's never any discussion. But the minute the fracture is on the other side of the same joint, then suddenly the philosophy often changes. And there's usually some discussion now whether this needs surgery or not. And all the complications of recumbency and early mobilization and all the benefits of early surgery get forgotten. So typically, this is what happens. This is a case where a 82-year-old comes in and she's sustained a low energy fall. And as we've seen from Francis' previous slides, that, if you have, impaction of the dome, this is the classic gull wing sign. It's confirmed on the CT scan. There's, damage to the femur head. You've got some displacement at the joint line. So this patient gets seen, and what then happens is that she gets sent home, and to mobilize non-weight bearing and come back at 4 weeks. And she comes back at 4 weeks, and she's looking like this. Now, what's happening here is that she's starting to medialize. That's the femur head medializing. And even at this moment, nothing happens. And then she gets told to come back at 8 weeks. And by 8 weeks, she's got, established femur head impaction. This is never going to unite. Even if it does unite, she's likely going to get pain. And this is her at 12 weeks. And now she's got, she's not mobile. She's in agony. And for someone that's 87 years old, 3 months of your life when you are that age is a long time. It's a very high proportion of your remaining life. And also because if you haven't been mobilizing well for that long, you lose muscle mass, they get sarcopenia. And we know that the elderly don't do well, with muscle mass. They're often not able to do non-weight bearing, with crutches or even with a walking frame. So the question is, if we go back to the start, was it the correct decision to treat this patient non-operatively? So what you think about that? We've heard already from Fran that, look, there are instances where fixation is the preferred intervention, but there are instances, as we've seen, where that you can expect a poor outcome with fixation compared to replacement. And I'm not going to go through the list. It's there on your left. So those are the things that predispose to poor outcome if you choose to fix. And in those instances, almost within 2 years, those patients are going to be back for total hip arthroplasty. So the question is, can we, is there merit in considering replacing them acutely, which is what we call fix and replace? So if we consider fix and replace, it's something that can be performed acutely, because so often the thinking is that, we'll send you home, we'll let the fracture heal so you can get good bone stock, and then you come back, then we can do your fixation, your replacement at that time. Whereas, if you do a fix and replace early, it offers them immediate weight bearing, and importantly, you avoid another operation later on when you have to convert them to a total hip. And then the other concern has always been that if you do a primary fix and replace, then you need to use complex revision type acetabulum cups, like we've seen now from Francisco, which have looked great, by the way. But my point is that it's not always necessary to use complex arthroplasty components. So my discussion tonight isn't going to be an exhaustive literature discussion. I'm just going to use case examples to communicate our current practice and our philosophy. Now, as a country, we're famous for the Big Five. So again, if you ever come visit, make sure that you go and visit our wonderful national parks and get to witness the Big Five. So my Big Five for the evening is going to be 5 case examples. Like I said, that we'll just discuss our philosophy and practice. So the first case is an 82-year-old male, and many of them are going to be low energy falls. So she comes into hospital, and that is his first X-ray. He's got immediately the concern is, you've got impaction. If you measure the distance from the lesser shock to the ischial tuberosity on this side, and on this side, he's medialized, because often the medialization is not well appreciated, but if you look out for it, it's almost always there in the elderly. And then on the CT scan, again, the concerning parts, there's impaction of the dome. There's a remaining intact part of the dome. So for reference, that weight-bearing surface should be in line with this. So this is proximalized and medialized. And then on the axial cuts, again, we can see the impression fractures on the femur head. And on the sagittal cut, again, more femoral head damage. So what happened is that, again, he gets seen in trauma and he gets sent to a step-down facility to go and wait and come back after 6 weeks and to reassess after 6 weeks. And of course, this is what happens. He is just too painful. He fails to mobilize and he comes back. This is now at 2 weeks and he's looking like this. So what are the challenges facing us here now? One, he's in pain, so it makes little sense to continue with the non-operative plan. So, if you look at the dome, so this femur head is now proximalized. So it's basically damaged all the bone that you have in the dome. You've lost length and you've also lost offset. So those are the things that you need to correct. But importantly, his fracture still involves the anterior column. So you need to offer protection for the anterior column. So the philosophy here is that you need to, firstly, like I said, fix the anterior column. So we've done this via a stopper approach. So this is staged surgery, but when we stage it in the same sitting, same surgical procedure. So first is supine, and we do a stopper approach and put the supraperitoneal plate on. Now you've got protection of your columns medially, and the component that you put in is not going to mobilize, is not going to medialize. Then you close the front and put him on the side. I suppose this is where it may be important now if you are trained in anterior hip surgery or direct anterior approach, like we saw from Fran, that you can then even proceed with the hip arthroplasty in the supine position. But I'm not trained in that. So we turn them on the side. And now you need to address this bone defect that's inevitable here. So we take the femur head and use it to fill the defect. And what's important here is that you need to put screws in the cup, because normally you rely on a press fit for your fixation of the cup. But in this one, because of the soft bone stock, and also your columns are not great in terms of bone quality, so you need to rely on ways to augment your fixation. And routinely we use screws in the cups. And initially we used to use a few screws, but now basically as many as you can put in. So try and go into the ischium here, you go up into the ilium, and sometimes even in the superior pubic ramus. And then of late also we've been using a dual mobility cup to prevent dislocation, and we'll discuss that a bit later. So that's the first example of someone who came in. There was attempt at non-operative fixation, which I think at this age and with the fracture that he came with, it's probably just more prudent to, to intervene immediately. And then for the second case, again, another elderly gentleman, low energy fall. And again, if you look at his X-ray, it's actually amazing how virtually all of them look identical. And I was looking at Francisco's X-rays. I'm like, oh, that looks like my typical geriatric patient. So fortunately, there are very frequently occurring fracture patterns, which make planning a little bit easier. So this one, again, same problem. Look at the offset. So this is medialized. You have a break in the anterior column. But here, this is an associated both column fracture. There's a break in the iliac wing. And there is impaction of the dome. And now, if you're not certain about femur head impaction, then you do a CT scan. And so the CT scan confirms, firstly, the both column component. Luckily for him, it's an incomplete iliac wing fracture on top. And this is comminution on the medial aspect or quadrilateral surface. And also this confirms proximal migration of the femur head. So what we opted to do for him, so luckily for him, this was fairly acute. So again, similar philosophy, I put him on in the supine position, plate the anterior column and get your protection medially. And then importantly, use the bone graft again to from the femur head to get more bone stock. And then, so again, same posterior approach, dual mobility cup. And so the two things I wanted to highlight here are that almost, routinely we use a high offset just to get better abductor tension. Secondly, we use a dual mobility cup, again, to try and mitigate against dislocation. And also here, we've got a few more screws for him. The screws going up there, and there's a few more screws if you look here, 1, 2, 3, 4. So 5 screws in total. So that's another, typical case of how to address these acutely. It looks like he's a little bit shorter than the other side, but the pelvis is tilted. So his discrepancy was less than 2 centimeters. Case 3 is a slightly younger patient, but osteoporotic and osteopenic bone. And so here immediately, and these are the X-rays that are often easy to miss and are often reported as being normal by the casualty officers and sometimes even the radiologists. So what you always suggest is that when you look above the femur head and you see this triangle here, that's almost always the posterior wall. So that's displaced proximally. And also, I always say the hip joint does not sublux. No, it only, posteriorly, it only dislocates. It can sublux medially, but posteriorly, it often just pops out. And also, if you see the double shadow here, you've got the dome, you've got the femur head, but there's no clear joint margin, which means that there is some overlap between the femur head and the acetabulum. And for old time's sake, this is the Juday view showing the posterior wall fragment. So if you do a CT scan for her, it confirms the damage to the femur head. It confirms involvement of the posterior wall and see how much of it has been lost. It confirms the comminution of the posterior wall on this view and also on the 3D view. So what Fran spoke about is that, if you have a posterior wall comminution, that's a poor prognostic factor. But also where it becomes important is that if you have posterior wall presence and it's comminuted and it's patients with soft bone, it's almost impossible to fix the posterior wall because it is just so soft and mushy. So what we did for her is that we basically discarded her posterior wall and fashioned the new posterior wall from the femur head. And so this is all done from the posterior approach. So that's a femur head, you fashion it, and we put a new posterior wall for her. These are the screws holding the posterior wall, and supplementing some part of the dome also, and then a posterior. So these are the two screws. Then you get the posterior column or plate on the posterior column that's now supporting the new posterior wall that we fashioned for her. And this wasn't the joint mobility. This is just normal articulation. And of course, as standard, like I said, we do a high offset stem. And if you look closely, there are two screws in the cup. And of course, this is one of the complications that you have to worry about. And that's why I made and emphasized the point about dual mobility, if you can, and the high offset. But so she dislocated a few days after the surgery, but the cup is stable and the posterior wall fixation is stable, so we could reduce this. And this is her at 2 years, and everything is well healed. So the learning point here is that dislocation remains a problem if you do it acutely. So you need to have a plan to mitigate against dislocation. And then fourth case is a 75-year-old female. She was referred to us from George. Now, George is one of our regional hospitals, and it's a 4.5 to 5 hour drive on the road. And that becomes important if you have someone like the next patient that I'm gonna show. So she presents to George with a central dislocation of the femur head. And of course, she's then taken to theater, and I mean, everyone will agree that this requires immediate reduction. So goes to theater, and that is the image we got, that this was in theater on the C-arm, and it is reduced. But unfortunately, by the time she went for formal post-reduction x-rays, the femur head is dislocated and is medialized again. And in slightly younger patients, this is always a concern because you've got a very sharp acetabulum corner here, and there's always point loading on the femur head. So they tried to reduce her, and they failed. And this was a CT scan, again taken unfortunately at this, with the hip still dislocated because they could not reduce it. And here, this is what I was talking about. This is what happens to the femur head. Invariably, you get an impression fracture at this corner here if it's unreduced. So what do you do in a situation like this? So they took her back to theater, tried to reduce her, and still failed. And they tried what Francisco showed us earlier, which is a pin into the lesser trunk to try and give a lateral force, but this also did not work. And this is about 7 to 10 days now that she's waiting with the hip dislocated. So now at age 75, is it really worth trying to planning to fix this? Because it's already been out for, like, say, for 10 days. There's damage to the femur head. She's 75 years old, and even if you do fix her, you're unlikely going to get a perfect anatomical result from the fixation, which means she's going to be back in no time for conversion to arthroplasty. And we know that arthroplasty performed for failed fixation or for reconstruction of fixation has poorer outcomes compared to primary arthroplasty. Of course, primary in this case still being very relative compared to primary arthroplasty for simple arthrosis. So what was the plan for her? So the plan was to do a fix and replace. So put in a supine position and do a stopper approach and put a suprapectineal plate. And now I had a plane to catch. So I spoke to the arthroplasty fellow and said, look, after I'm done with the front part, you must come and put the hip in, and you'll change to the lateral position, anterolateral approach, and a multi-hole cup and unsymmetric stem. So that's what I left him with. So this is our surgical episode. So took her into theater, and so I always put a shunt pin up the femur neck, which helps to lateralize the femur head when you do the fixation. And importantly here, you can appreciate now that the femur head is completely flat on top here. So it's been completely, well, it's been grinding away against the acetabulum. So that's the plate coming on. We've got the the anterior column now reduced, and that's the plate now fixed. So this is now ready for arthroplasty. Flip her over, and so then, like I said, I left, and this was the post-operative result with the arthroplasty. So what are the learning points from this case? One is that these are complex cases, and they need appropriate expertise. And if you don't possess the expertise yourself, then you need to get expertise. And in this case, if you're a trauma surgeon, it's often that you will need someone with arthroplasty. But I mean, I do my own arthroplasty for my cases. And importantly, the medial wall is quite soft, and so are the other columns actually. So if you're used to doing a press fit in these cases is not possible. So what you need to do is just gentle hammer blows, sit the cup, and when it's in the right position, even though it won't give you the feedback that you normally get with a press fit, then you need to put in the screws. So for her, the decision was, do we leave her like this? Because I mean, the cup is in place, just that she's she's medialized, but of course you correct that by giving her a higher offset and more length. So in terms of length, she's actually not, I mean, she's got equal legs, if anything slightly longer, which is what you want. Offset is not too dissimilar to the other side, maybe a little bit higher. So the only thing here is that it's just not a pretty X-ray to look at. So like I said, the learning points are that you need to and also see how medialized this supraepicranial plate is. So basically it's almost bent over. So yeah, so there were a lot of learning points from this case. So I said I wasn't going to bore you with literature. So, but I mean, this is like the latest review that you can find. So it's a systematic review, and this came out earlier this year. So what do we know from it is that fix and replace has got very similar functional outcomes, compared to acute ORIF and then a delayed total hip arthroplasty. So at 3 years, they're all going to be the same. But the difference is that there are lower revision rates if you do fix and replace acutely. But importantly, there's reduced cost, for the healthcare system, but importantly for the patient as well, because it's just one operation, one hospitalization, and of course you can stage it, like I said, but try and staging it, it means you can do the front part or the fixation, and then you do the replacement maybe 2-3 days later, but within the same admission, depending on your patient's physiological status. But if patients are able to take one operation, then rather just do both in one sitting. So what are the take-home messages? So you need to recognize poor prognostic factors early. And the elderly, like I said, do not tolerate non-operative care, especially for displaced fractures, because they cannot do, a toe touch. They cannot walk on crutches. It's just very difficult for them. And they lose muscle mass very quickly, so they get sarcopenia. So the same aggression that we show in treating neck of femur fractures needs to be shown when we're treating the acetabulum fractures. And acute fix and replace is a viable option, and it has good results. It can be performed in one go, like I said, or if the patient conditions dictate, then of course you can stage it. You need a multidisciplinary team, and you need a multi-hole cup. You need to place it gently and put screws on the cup. And that is the end of my presentation. So if anyone needs to reach out, you want to come and visit Cape Town, that's my email address, and you are more than welcome. Thank you very much. Okay, so I'll stop sharing my screen.
That was a great presentation, Professor Sithombo.
Thank you. Thanks, Brad. Okay, Francisco. So I'm gonna kick off now with, so guys, so feel free to put your questions on the chat. So on one of your videos, you were injecting something into the wound, and then you said that you inject tranexamic acid. Do you do it into the wound site or intravenously?
Both. When we induce the anesthesia, we administer 3 grams to the patient. And once we finish, while we are closing all the layers, we leave in place 3 grams of tranexamic acid too. And it's really, really useful. We have learned that from the total knee arthroplasties, and we have 0 necessities for blood transfusion in total knee replacements. So that's why we started to do that in acetabular fractures too. And it's really, 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 really inexpensive because it can be like €2. It's a really cheap medication.
Okay, no, that's very impressive. I mean, look, I know obviously now from the infection guys as well that you can throw, antibiotic powder into the wound, because normally what I do is I inject Flow-Seal or Surgiflow into the surgical site and then close.
Yeah, but Flow-Seal is €300. Tranexamic acid is €3.
Okay, well, now I know. But thank you for that tip. And then, so here's a question for you. It says, when do you use infra versus suprapectineal plates for anterior?
Yeah, I would say that in most of the cases, I will say 99%, I use suprapectineal plates because there is really, really commonly involvement of the anterior column. So I use suprapectineal plates. With that, you can control both the quadrilateral plate and the anterior column. The biggest problem that I have never had is if you have to remove that plate. I don't know if you have ever needed to remove that plate because it has to be really, really tricky.
Yeah, look, the answer is once I've had to, and I prayed I prayed that I never need to remove it again, because also the scarring of the anterior column, especially with the stopper approach, then the vessels get pulled down on very close to the plate. So look, also for me, I think exclusively the suprapectineal plate for the reason that you've given. But the other advantage is that because it's sitting on suprapectineally, if you need longer screws into the posterior column, then it offers you the opportunity to put longer screws going down parallel to the SI joint. Unlike the infrapectineal plate, which goes from medial to lateral, so the screws are a little bit shorter. Okay, I don't know if that answers your question, TQ. Okay, so there's a question from Kirsty Berry. What fracture patterns do you choose to do pararectus over the stopper approach?
Well, that's a tricky thing because more than the fracture pattern, I would suggest to use it if you are more familiar with the approach, because I guess that if you add the lateral window, you can address almost all fractures that can be addressed by the pararectus approach. So it's more a matter of experience with the approach than the type of fracture. I have to tell you that I am an stopper surgeon. I like that approach so much. But of course, you have to combine and you have to know different approaches. And I tried the pararectus approach. And in the beginning, you are not really comfortable with that approach because everything is in the middle. You have to be mobilizing and creating windows, and you are not as comfort as you are doing the stopper approach. Maybe I will go for a pararectus approach if I suspect that I'm going to have any problem with the vessels. If I have, for example, one fracture pattern that compromise the vessels, maybe I will go for that approach because it's gonna be more easy if you have to fix and suture any vessel lesion.
Yeah. Okay, great. And then I'm just gonna add on to that answer, Christy, to say, look, also it depends on your anterior column fracture, because if your anterior column fracture line goes right against the pubic symphysis and you want to cross to the other side with your plate, the pararectus approach doesn't allow you to cross to the other side when you plate. That's the one disadvantage. Its advantage, of course, is that if you need to put screws into the posterior column, long screws, you can do that without needing to do a second lateral window for the screws. But for me, probably its biggest advantage is in patients who've got a hernia and a mesh. because to do a stopper approach in patients who've had a mesh for a hernia is often, it is doable. It's just that the landmarks are messed up completely, but it's doable. So I mean, I've had Marius Kiel, visit us here in Cape Town, and he showed me lots of stopper approaches. I have also done it. I'm showing lots of pararectors, but I must say for me, it's the same reason that I just didn't want now to learn a new procedure, which obviously now includes its own learning curve, its own complications, when I felt that I can address most of what I need to address with the stopper, and if required, the first window. But I mean, Marius uses the pararectors virtually for everything, but there are some instances where he will still use a stopper approach because the pararectors has got some limitations. Yeah. And then I have another question for you here. So I see that you use almost exclusively 4.5 screws for your fixation. Is that a personal choice, or because I use 3.5 exclusively?
I feel that the bigger, the stronger is the purchase of the screw. So the only 3.5 screw that I use is when you use these supraperitoneal plates, when the screw that goes to the posterior column, to the extension of the plate. But for the rest, I prefer the 4.5.
Yeah. Okay.
Especially in elderly patients, because the purchase is bigger with those screws.
Okay, so a question from Maqungo, and this is going to do with the posterior hip dislocation with the comminuted posterior wall. So is your preference hip arthroplasty or fixation?
I will go for an arthroplasty.
Yeah.
If you want, I can share with you one case. I don't know if we have time.
I think let's take it, because there are no more questions anyway. So I think, let's take 5 minutes and see your question.
Okay, so
and see your case. And then to continue, Makabonge, whilst we're waiting for the case, I think the concern there is that also for posterior wall comminution, with the current plates, it's often quite difficult to get a proper purchase. And so often the posterior wall just basically displaces under the plate. So if it's comminuted, elderly patients, I think it's just safer to just go for it and replace primarily. Okay.
I don't know, Sithombo, if you can see my screen.
Yes, we can. Yeah.
You can see here, this is an 82 years old old woman with this. It's not quite a comminuted posterior wall fracture, but it has a deformity of the femoral head. So that's the technique that how I try to address these fractures. I try to combine. I try to fix as best as possible the posterior column, the posterior wall, in order to get more contact with the implant, with the cap. An important part is when you do a Cocker-Langebeck approach, you have to release the distal part of the gluteus maximus, and also you have to flex the knee. Once you are in the joint, you can find that's a mess because everything is disturbed. You can find the rotators, release the hematoma, release the bursa, and there you can check the fragment, the big fragment that is displaced. That's the place, the fragment. Then I go with the hip dislocation. Of course, you need planning. You have to plan your surgery with OrthoView or whatever you can use. And also, I love to use 3D planning in order to define the fracture patterns. You establish where do you want to make your femoral cut in order to reproduce what you have planned. You can see the deformation of the femoral head. You just identify the ligament, the transverse ligament, in order to know where do you want to go with the adversion. You have to release part of the ischium. I love to use the cup retractor. And here you can see also the impaction of the dome. So that's not possible to reconstruct with an osteosynthesis. That's gonna give you a bad result. Then you try to ream the anterior part of the acetabulum in order to improve the contact with the implant, release and remove the rest of the cartilage of the posterior wall, and then place it in its more anatomical position. Once the trial is covered, I fix temporarily with a key wire, and I add some screws in order to place the posterior wall in its position. It seems that you want the anatomical reduction. So the more anatomical the reduction is achieved, the less implants you can use. And then you just adapt a posterior wall plate, again with 4.5 screws, superior and distally. So it's almost like a native acetabulum. Then you keep on with the reaming until you reach the proper size. You graft the cavity defect where the impaction was. You just press the graft going in the other direction with the reamer. Here you have that we got a very good reconstruction. I like to use trabecular metal in order to increase the first grip. Here's the intraoperative vision. You have to supplement with screws. That's mandatory, as you said in your presentation, at least 3 or 4. You have to prepare the femoral canal. In most of these fractures, I go for cemented stems because it's supposed that as they are low impact traumas, the quality of the bone is not as good as for using a non-cement stem. And then you go with the trials. You have to reconstruct the measurements that you plan before the surgery. Then you go with a liner, the stem, cement with double prophylaxis, antibiotic prophylaxis. Double check the femoral heads. And once you are happy with you go with the final femoral head and with the closing. That's the postoperative X-ray. That's the day 2 after the surgery. You allow full weight wearing to this patient. And this is the follow-up of the patient, 82 years old, that was able to walk 1 month after the surgery without the aid of any crutches or walker. I don't know if we have any other question since we have seen this case.
Yeah. No, thank you, friend. I mean, that was a fantastic case to show. So there are no other questions on the chart. So I think